Hello, everyone, and welcome back. Today, I want to talk about something that comes up constantly with new clients that we see. People who took antibiotics like Rifaximin for SIBO, felt better for a while, and then watched their symptoms slowly come back. One of the most common stories I hear from new clients goes something like this. They were finally diagnosed with small intestinal bacterial overgrowth, or SIBO, after months or sometimes years of digestive symptoms. During that time, many people are told they have irritable bowel syndrome, IBS, or are advised to follow a restrictive dietary approach, something like the low FODMAP diet, to manage symptoms. And eventually, their doctor prescribes antibiotics like rifaximin. And for the first time in a long time, the person starts to feel better. The bloating eases up, digestion feels calmer, and the person can eat normally again, a little more normally again. But then a few weeks after finishing the medication, the symptoms slowly creep back. I remember one client, I'll call her Sarah, who told me she felt almost 90% better while she was taking rifaximin. She was hopeful that she had finally found the answer, but within about 2 weeks of finishing the course, the bloating, gas, abdominal pain, and food sensitivity she'd been dealing with for years began returning almost exactly the way they had before. So if you're listening and you've had a similar experience, just know that you're not alone. We see this all the time in our practice, and many people do notice significant improvement during treatment only to see their symptoms return not long after the antibiotics are finished. Others might go through multiple rounds of treatment and feel like they're stuck in a cycle where their symptoms improve temporarily but never fully resolve. And that just becomes this frustrating and all too common cycle of SIBO relapse. And this experience can be incredibly discouraging, especially after finally feeling hopeful that something was working. And the important thing to understand is that antibiotics like rifaximin can absolutely play a helpful role in addressing SIBO. But in many situations, they're only one piece of a larger puzzle. When symptoms return quickly after treatment, it's often because one of three important factors hasn't been addressed. So, in today's episode, I'm going to walk you through the three most common reasons people experience SIBO recurrence after antibiotics and what needs to happen differently for the results to last. So, reason number one is that the wrong overgrowth pattern is treated. This is one of the biggest reasons antibiotics sometimes don't seem to work for SIBO. And it has to do with the fact that not all SIBO is the same. While the term SIBO generally refers to bacterial overgrowth in the small intestine, different gas patterns that are identified through breath testing reflect different microbial activity and can be associated with different symptoms and therefore different treatment approaches. So these patterns are usually characterized based on the gases the microbes produce, and we identify those gases through breath testing. And they are hydrogen, methane, and hydrogen sulfide SIBO. So those become our three subtypes of SIBO. And each of these patterns behaves differently in the body, which is why the treatment approach can vary significantly between them. Also, the treatment approach just is different as far as the types of agents that kill certain microbes between the three types are different. So, rifaximin is one of the most commonly prescribed antibiotics for SIBO, and it can be very effective in the right situation. I mean, it's a wonderful treatment actually because it works locally in the gut, locally in the small intestines, specifically to reduce that bacterial overgrowth that's caused by hydrogen producing microbes. However, other patterns involve different types of microbes that don't respond the same way. For example, methane overgrowth involves different types of microbes that don't respond the same way. So, in the medical literature, methane SIBO is now often called intestinal methanogen overgrowth, or IMO or EMO. These organisms respond to different antimicrobial strategies than the hydrogen producing bacteria, which is why rifaximin alone is often not sufficient. And what we often see in practice is that methane overgrowth is typically addressed best with a combination therapy rather than just rifaximin by itself. I have another episode where I explain this in much more detail, and we will link to that episode about how to fully address methane SIBO in the show notes. But for the sake of today's conversation, just know that the type of treatment needs to be targeted toward the type of SIBO. And the agents, meaning the antibiotics or herbal antimicrobials that are used for the different three types, are unique to each type. So with methane, we're looking at rifaximin in combination with another agent, which I describe more what those agents are in that separate episode. Hydrogen sulfide, the third type, those patterns are another situation where rifaximin alone often doesn't fully address what's going on. Hydrogen sulfide is produced by sulfur-reducing bacteria that rifaximin does not directly target. And in some cases, rifaximin can still lead to partial improvement because it can reduce hydrogen producing bacteria that hydrogen sulfide producers rely on as a fuel source. And that the same is true with methane SIBO. So with methane SIBO, we know we have hydrogen producing bacteria there. With hydrogen sulfide SIBO, there may also be hydrogen producing bacteria. So you can still see some improvement. It's just not targeting the microbes that might be contributing the most to your actual symptoms and the overgrowth. In the case of hydrogen sulfide, rifaximin can lead to partial improvement because it is reducing those hydrogen producing bacteria that the sulfur reducing bacteria are relying on as a fuel source. But when the sulfur reducing organisms themselves are not addressed, symptoms often return after the treatment ends. Addressing hydrogen sulfide patterns often involves a much broader approach that may include supporting sulfur metabolism, using binders to help manage excess hydrogen sulfide, and sometimes incorporating specific herbal antimicrobials that are used to target sulfur-reducing bacteria. And I go into much more detail about this in my episode on how to fully address hydrogen sulfide, SIBO, so we will also link to that in the show notes. And because rifaximin is often prescribed as a blanket treatment for SIBO, some people are only addressing part of the overgrowth. So that's why a lot of people tend to report one of two experiences. Either the antibiotics didn't seem to help at all, or they felt better during treatment, but symptoms returned soon after stopping. But even when the correct microbial pattern is targeted, when the correct treatment is used, there's another common issue that I see all the time, and that's number two, that the bacterial load often hasn't been reduced enough yet. This is another very common reason that symptoms return after treatment. And it's simply that the bacterial overgrowth hasn't been reduced enough yet. When bacteria accumulate in the small intestine, the population can become quite large, and very often it takes more than a single round of treatment to meaningfully bring those levels down. What we often see in practice, it's very common for people to need more than one round of therapy to meaningfully reduce the overgrowth. And usually when breath test gas levels start very high, it often takes multiple rounds of treatment to bring those levels down into a normal range. And the SIBO specialist, Dr. Alison Becker, she talks about how a single round of antimicrobial treatment, which is 2 weeks if we're talking about prescription antibiotics, or 4 to 6 weeks if we're talking about herbal antimicrobials, tend to lower gas levels by roughly 20 to 30 parts per million on average. And in our practice, one helpful way we often estimate how many rounds of treatment a person is going to need is by looking at the peak gas levels on the breath test and using the typical reduction as a rough rule of thumb. How many rounds may be needed to bring the gas levels down? So, for example, if someone's hydrogen level peaks around 100 parts per million, it's very unlikely that a single round of treatment will bring those levels all the way down into the normal range. Using that rough reduction of about 20 to 30 parts per million per round, someone starting around 100 parts per million would typically need at least 3 rounds of treatment, and sometimes more, to bring those levels down into the normal range. That doesn't mean the first round didn't work or it didn't do what it was supposed to do. It just means that the bacterial population hasn't been reduced far enough yet. It's actually similar to something most people already understand about antibiotics for infections. If someone's prescribed a 10-day course of antibiotics for a sinus infection, most people know that stopping after 3 to 4 days, even if symptoms are starting to improve, usually isn't enough to fully clear the infection. The remaining bacteria can simply just begin multiplying again. And something similar can happen with SIBO. If the treatment reduces part of the bacterial population but doesn't bring it down far enough, the remaining microbes can begin rebuilding once the treatment stops. And our small intestine is a tremendously long and large area. So we're talking about a much larger body of bacteria in many cases when we have an overgrowth in that area. And unfortunately, many people with SIBO are only prescribed a single round of antibiotics. That's probably the most common way we see SIBO addressed. And the pattern we often see looks something like this. You get your one round of antibiotics, symptoms improve during treatment, often, sometimes they don't. The medication stops, and then symptoms gradually return. And when the treatment stops too early, that bacterial population just hasn't been reduced enough. And another important factor is timing. Very often, when new clients come to us, they tell us they were prescribed a single round of antibiotics and then told to wait and see how things go. If symptoms return, maybe 6 weeks or 6 months later, another round may be considered. The challenge with that approach is that bacteria in the small intestine can begin rebuilding fairly quickly once treatment stops. So by the time another round is prescribed months later, the overgrowth has often already reestablished itself. So think of it like if you're trying to drive to a destination that's 3 hours away. So let's say you drive the first leg of the trip for 1 hour and the entire trip is 3 hours. But instead of continuing from there for the second leg of the trip, you drive all the way back home first. And that's essentially what can happen when months pass between treatment rounds. The overgrowth can rebuild during that time, so you end up right back where you started. And then when you begin treatment again, you're only getting back to the same point you reached before rather than actually progressing further toward clearing the overgrowth. This is why in our practice, when we're working to fully reduce the overgrowth, we typically keep treatment rounds closer together rather than leaving long gaps in between. Because repeated rounds of prescription antibiotics are not always ideal, we often use herbal antimicrobial protocols as part of the process. And that allows us to keep reducing the bacterial population while also supporting a healthy overall gut environment and protecting your large intestine microbiome. After a couple rounds of treatment, we typically retest so we can see how much progress has been made and determine whether additional treatment is still needed. And that way, we're not continuing blindly, but we're also maintaining enough momentum to meaningfully bring the overgrowth down. A client I worked with named Daniel, he had been told he had SIBO about a year before we started working together. When I asked what treatment he had done, he told me his doctor had prescribed a round of rifaximin. He said it had helped a little at the time. His bloating had eased up somewhat and meals felt slightly easier to tolerate, but the improvement was not dramatic and he never felt like things had fully resolved. Within a few weeks, his symptoms gradually drifted back to where they had been before. When I asked what his breath test numbers were, he had no idea. His doctor's office had just called him and said he was positive for SIBO and that they had sent the antibiotic prescription to the pharmacy. So I asked him to request a copy of the test report and send it over to me. When I reviewed his results, his hydrogen levels had peaked up to 108 parts per million. When I told him that number, he was surprised. And I explained to him, Daniel, no wonder you're still struggling. That level of overgrowth would almost never be expected to clear with just one round of treatment. And in situations like Daniel's, the first round of therapy often reduces that bacterial population somewhat, which is why people may notice some improvement, but it hasn't actually brought the levels down far enough yet. With a starting level over 100 parts per million, Daniel would almost certainly have needed multiple rounds of treatment to bring those levels down. So we ended up doing with him, he requested another round of rifaximin from his doctor. And then we were able to follow up with a round of herbals. And that's where we picked up and took it from there. And this type of story is incredibly common. We see versions of this every week in our practice at Nutrition Resolution. And many people listening to this episode will likely recognize their own experience in it. Even when the bacterial overgrowth is addressed successfully. So now let's talk about the third thing that happens. So let's just say we've addressed the bacterial overgrowth successfully. There's still one more critical factor that determines whether SIBO returns, and that is that the underlying drivers that cause SIBO have not been addressed. And that's the third major reason that symptoms often return after treatment, when the root causes that allowed the overgrowth to develop in the first place have not been addressed. In a healthy digestive system, several mechanisms are constantly working together to prevent bacteria from accumulating in the small intestine. For example, the small intestine has a natural cleaning wave called the migrating motor complex, which helps sweep bacteria and leftover food particles down into the large intestine between meals. Adequate stomach acid helps limit how many microbes survive the stomach and enter the small intestine. Bile and digestive enzymes also play an important role in controlling microbial growth and supporting proper digestion. When these systems are working well, bacteria generally don't accumulate in the small intestine in large numbers. But when one or more of these protective mechanisms becomes impaired, the environment in the small intestine can start to shift in a way that allows bacteria to build up. Alison Seebecker often teaches that there are around 40 different conditions and factors that can contribute to the development of SIBO. And in practice, it's very common. I notice most people have more than one factor. So we hear a lot about root causes in this space, and I like to call them root contributors because there's so often more than one thing that set up the digestive landscape to allow this overgrowth to occur. Some of the most common root contributors we see include slow motility in the small intestine caused by factors like food poisoning that led to antivinculin antibodies, caused by thyroid dysfunction or certain medications or other conditions that impair the migrating motor complex, low stomach acid or reduced digestive enzyme production, impaired bile flow, structural issues such as adhesions, scar tissue, or surgical changes to the digestive tract, disruption of the gut microbiome and its beneficial bacteria after repeated courses of antibiotics, and certain conditions that can slow intestinal motility. What's interesting is many of the different contributors described in the SIBO literature ultimately affect the same underlying mechanism, and that is the normal movement of the small intestine. The migrating motor complex acts as a cleaning wave that sweeps bacteria and debris out of the small intestine between meals. And when that system slows down, bacteria can linger in the small intestine longer than they should and begin multiplying. One of the most well-known ways this can happen is after certain types of food poisoning. In some people, foodborne infections can trigger antibodies such as the anti-CDTB and antivinculin that interfere with the nerve signaling involved in the migrating motor complex. When that signaling is disrupted, the small intestine's natural cleaning waves can become less effective, creating an environment where bacterial overgrowth can develop. When these underlying drivers remain in place, the environment that allowed the overgrowth to develop really hasn't changed. So even if antibiotics or antimicrobials temporarily reduce the bacterial population, the small intestine is still vulnerable to the same problem. And over time, bacteria can begin accumulating again and symptoms gradually return. This is why addressing SIBO usually involves more than simply reducing the bacterial overgrowth itself. It also involves identifying and supporting the underlying digestive processes that help keep the small intestine balanced in the first place, which is ultimately one of the most important steps in how to prevent SIBO from coming back. A cornerstone of our work with our clients at Nutrition Resolution is doing a thorough root cause assessment to identify the specific contributors involved in each person's case. So by the time someone is finished working with us, our goal isn't just that the SIBO has been fully cleared, but that we've put together a clear relapse prevention plan that's personalized to them to support the areas that allowed that overgrowth to develop in the first place. Another client I worked with, Melissa, she had already been through several rounds of antibiotic treatment for SIBO before we started working together. And each time she took antibiotics, her symptoms improved for a while, but the relief just never lasted. And by the time she came to us, she was starting to feel concerned about how many antibiotics she was taking. She wondered how many more times she was going to need antibiotics and what that might mean long term for her microbiome and her overall health. So, as we reviewed her history more closely, it became clear that the entire focus of her previous care had been just on reducing the overgrowth itself. No one had ever talked to her about the underlying factors that may have allowed the SIBO to develop in the first place. When I brought that up, she honestly had no idea where to even begin thinking about it. And like many clients, she assumed the only issue was the bacteria. But when we started digging through her history, we discovered she had a bit of a perfect storm of contributors. For one, she had been taking a proton pump inhibitor, omeprazole, for years for acid reflux. Long-term suppression of stomach acid can reduce one of the body's natural defenses against bacterial overgrowth in the small intestine. She'd also undergone a hysterectomy years earlier, which meant there was a possibility of small adhesions of scar tissue in the abdominal cavity. And that's something that can sometimes alter the movement of the intestines and create pockets where bacteria can accumulate more easily. On top of that, she had experienced multiple episodes of food poisoning over the years, and she was living with hypothyroidism. Both of these things can affect the normal movement of the small intestine. So when you look at all those factors together, it becomes easier to see how the environment for SIBO developed in the first place. And once we identified those contributors, our plan focused not only on addressing the overgrowth itself, but also on supporting the systems that help keep the small intestine balanced long term. We worked with her physician to ensure her thyroid function was well managed, incorporated the right type of abdominal manual therapy to help address potential adhesions, and supported her small intestinal motility as part of her longer term relapse prevention plan. And what's interesting is Melissa's acid reflux actually improved significantly once her methane overgrowth was addressed. Methane SIBO can slow digestive movement and increase pressure in the digestive tract, which can contribute to acid reflux symptoms. So as her digestion stabilized, she was able to gradually taper off her PPI with the guidance, of her physician. So that was the final thing to check off the list as far as something that was working against her in increasing her risk of SIBO relapse. And stories like Melissa's are incredibly common. When the bacterial overgrowth is addressed, but the underlying contributors are never identified, people often find themselves stuck in the same cycle of temporary improvement followed by relapse. But when those underlying drivers are understood and supported, the results tend to be much more stable over time. This is why a comprehensive approach is so important. When you look at the patterns behind why SIBO comes back, it really becomes clear that lasting improvement usually requires addressing several layers of the problem at the same time. Unfortunately, most often, this is not how SIBO is approached in standard care, where the focus is often placed primarily on reducing the bacterial overgrowth itself, and rifaximin tends to be the go-to antibiotic very often by itself, which may not be targeting correctly the actual overgrowth pattern that is present. So as we discussed earlier, not all SIBO behaves in the same way. Hydrogen, methane, and hydrogen sulfide involve different organisms and require different treatment strategies. So understanding which type is present helps guide the most appropriate approach. And then also The bacterial population in the small intestine needs to be reduced enough that the gut environment can stabilize. And that means continuing treatment long enough to meaningfully bring gas levels down rather than stopping after a single round before the overgrowth has been fully reduced. And third, it's important to identify and support the underlying digestive processes that help prevent bacteria from accumulating in the small intestine in the first place. And this is one reason that SIBO recurrence rates are often reported to be so high because the overgrowth can be reduced, but the underlying condition that allowed it to develop was never fully addressed. So that often means taking a closer look at things like small intestinal motility, digestive function, stomach acid levels, bile flow, and the gut-brain connection, and the overall microbial environment in the large intestine as well. And when those factors are evaluated together, treatment plans can be tailored much more specifically to the individual rather than relying on a one-size-fits-all approach. And in practice, this kind of comprehensive approach is what tends to produce more stable and lasting improvements instead of simply reducing the overgrowth temporarily. The goal becomes restoring the conditions that help keep the small intestine balanced over time. So, if you took antibiotics like rifaximin and your symptoms returned shortly afterward, it usually doesn't mean the treatment failed or that nothing will work. More often, it means the overgrowth was not fully addressed yet, either because the specific overgrowth type wasn't targeted appropriately, the bacterial population was not reduced far enough, and or the underlying conditions that allowed it to develop in the first place were never identified and supported. When those deeper drivers remain in place, the small intestine can gradually drift right back into the same overgrowth pattern again. And the encouraging news is that when those factors are properly identified and addressed, many people are able to finally break out of that cycle and finally see lasting resolution in their symptoms. So if you've been dealing with SIBO that keeps coming back, you're likely exhausted from this cycle. Many of the people who eventually work with us arrive at the same point. They've tried multiple rounds of antibiotics, experimented with different diets, and follow the recommendations they were given, yet the symptoms keep resurfacing and they're left wondering what they're missing and continuing to search for answers about why their SIBO keeps coming back. In our experience, that turning point often comes when someone finally steps back and evaluates the full picture of what's happening in their digestive system instead of just continuing to chase symptoms alone. So, if you'd like help thinking through your situation and what your next step might look like, you're welcome to schedule a 15-minute strategy call with me. We will include the link to schedule that in the show notes. And in that call, we'll talk through what you've already tried, what may have been overlooked, and whether working together would make sense for you. Either way, I hope this episode was helpful today and looking forward to the next episode and join us next week. In a couple weeks, we're going to talk about die-off. I know that's a huge topic that many of you have questions about, so stay tuned for that. All right, guys. Well, bye for now.